The cabinet has approved the launch of the Ayushman Bharat Health Protection Mission. In fact, let me just try and get out the details that have come in. They're sketchy at this point in time, but we now do have confirmation that indeed the Ayushman Bharat program has been given the cabinet's approval. I'm just trying to look at the details. The scheme has a benefit cover of 5 lakh rupees per family. The target beneficiaries of the proposed scheme will be more than 10 crore families. The NHPM will subsume the ongoing centrally sponsored schemes, which is the Rashtra Swasthya Bima Yojana and the Senior Health Insurance Scheme. It will have, and I'm just, apologies, to ensure that the funds reach on time, the transfer of funds from the central government to the state health agencies may be done through an escrow account directly in partnership with NITI Aayog. A robust, modular, scalable and interoperable IT platform will be made operational, which will entail a paperless, cashless transaction. Beneficiaries can avail of benefits in both public and impaneled private facilities. To control costs, the payments for treatment will be done on a package rate to be defined by the government on an advance basis. Sujatha Rao, a quick comment from you. This is essentially what we've already heard so far in the budget and post the budget from Amitabh Kant and other members of the NITI Aayog on CNBC TV 18. So it's a reiteration of that. What do you make of it?
I mean, you know, it's a good thing that the government of India is taken this step, but there's nothing new. This is all being done in states like Andhra or Telangana. We're already covering 85% of our population. We have these IT platforms. We have all this kind of whatever they are now trying to announce and do. So, you know, whether it's Kerala or Tamil Nadu or Karnataka, at least the southern states are pretty well covered with the insurance programs for the poor. And it's the same hospital inpatient treatment being offered and so on. So there's going to be no additionality of this program where the people of the south are concerned. But in the north, the implementation is going to face a challenge, largely because large number of places don't have the supply in position. So, you know, that's going to be a big challenge, and it may trigger private sector to move into some of the underserved areas, but then at the same time we need to really sort out and see how and when and what terms. But my problem is that, you know, this whole package rate kind of approach is a very simplistic way of doing things. What I'm right now studying, for example, is how are we pricing? How are we pricing services under this government-sponsored or even commercial insurance? It's a big black box. Shirin, you'll be amazed to see how there is no clarity as to why a hospital charges an X amount and another hospital charges another amount. So there is this basic question of pricing of services is something that we have lost a lot of time. It's a lot of hard work that is required to be done. Secondly, an institutional mechanism is needed. RSBY was studied. Lot of infirmities were identified, and if they are not corrected and a reform process put in place, I'm afraid the NHPS may meet the same fate as the RSBY. So, you know, the southern states, I understand, are not going to be buying in the 5 lakh coverage, and so let's see how it rolls out.
Okay, let me just again go across to Shailaja Chandra. And ma'am, I'm again reading out to you, you know, what has come to us from Cabinet. We are given to understand for giving policy directions and fostering coordination between centre and states, it is proposed to set up an Ayushman Bharat National Health Protection Mission Council at an apex level chaired by the Union Health and Family Welfare Minister. So that's one of the things that they talk about. They also talk about the fact that they believe this will have a major impact on the reduction of out-of-pocket expenditure. This will also cover almost all secondary and many tertiary hospitalizations except a negative list. A quick comment from you, Shailaja Chandra.
Well, once again, I would say that it is not talking about outpatients, which is about 90% of what goes on. You see, there are only 8% in the whole country account for hospitals. In the whole country, 8% of all health facilities are hospitals. The rest are a whole lot of single practitioners, and that is where people go. Number two, I think that if you have a scheme like this, it is important that people are able to, if there's a mission mode, wonderful. The NRHM was a resounding success. We brought down maternal mortality, infant mortality, the institutional deliveries went up because it was in mission mode. But simply calling it mission mode is not enough when it comes to this kind of a healthcare delivery. That was aimed at reproductive and child health. So you knew all the little linkages that go into reproductive and child health. In the case of this Ayushman, it is a whole range of diseases caused by lack of sanitation, caused by waterlogging, caused by mosquitoes, caused by tuberculosis. All these things come up to the surface when a man badly needs a hospital and hospital care much after the problem has started. So I am saying that this kind of a mission mode will only work if they are able to somehow nab the people who suffer and through some GIS mapping, through GPS system, catch hold of them and see that the referrals are made quickly. If that is done, I would give full marks. But I don't think that has been factored in. That must be factored in.
Okay. Okay, let me go across to my colleague Rituparna Bhuyan. He's been speaking with government officials. Ritu, what more can you tell us in terms of the cost of this scheme and other details?
Well, according to the government, the scheme will be carried through what is known as package rates, which the government will define. I guess there will be more negotiation with the insurance companies regarding the package rates. And also, 40% of India's population will be covered under this. However, as our guest pointed out, there is no clarity on if outpatient-related issues will be covered by this. But state governments will have to set up state nodal agencies that will basically implement. State can tie up with a trust or with an insurance company to roll out this scheme.
All right, that is what we are given to understand at this point in time. Again, I'm giving you more details in terms of the implementation strategy at the national level to manage an Ayushman Bharat National Health Protection Mission agency will be put in place. States and union territories would be advised to implement the scheme by a dedicated entity called a state health agency. They can either use an existing trust or society or a not-for-profit company, state nodal agency, or set up a new entity to implement the scheme. States and union territories can decide to implement the scheme through an insurance company or directly through a trust society or use an integrated model. On the implementation strategy, Sujatha Rao, quick comment.
Well, it's a very challenging and a very complex issue. And as I was saying, now what the point is that they're going into the market and there is a competitive environment that's going to be created between the government and the private sector, where this entity is going to be purchasing services from both of them. Now, if you don't really improve your public hospitals, then they will deteriorate over the years because they can, the private sector will always have a upper hand in the perception of people's mind that the quality is better.
Sorry, I'm interrupting you.
They need to put in investment.
I'm sorry, I'm interrupting you. We've got Mr. Vinod Paul, member of the NITI Aayog, who's worked on this scheme, joining us now on CNBC TV 18. I'd appreciate it if you can throw your questions to Mr. Paul as well and the clarifications that you have. Mr. Paul, we understand that the cabinet has now approved the National Health Protection Mission, the Ayushman Bharat scheme. One question that Shailaja Chandra and Sujatha Rao both had was that will this not cover outpatients at all in any form or fashion?
Well, please remember that our pursuit to a universal health coverage historically happens in an incremental manner, progressive realization. So in this particular phase of our effort toward that goal, we are covering hospitalization at the secondary and tertiary levels. The other part of Ayushman Bharat deals with establishing a comprehensive primary health care system in the country, building from where we are currently, which is largely reproductive, maternal and child health and a few communicable diseases. Once that is ready, the outpatient services would be available in the public sector, and at that stage, all this will get connected.
Okay.
So Ayushman Bharat should be seen as a continuum of care being provided at the systems level to the nation. And so for the time being, outpatient services are not being covered. However, there will be huge effort to make the medicines available, diagnostics being made available free through the primary healthcare system and the public health system. So it should be seen as a complementary strategy.
Okay, so not initially, but you're hoping that that will eventually happen. So outpatient-related issues will also get dealt with. Okay. Mr. Paul, let me ask you, sir, because I know that you had a meeting with states a few weeks ago. So are all states on board now for the execution and the rollout of the Ayushman Bharat scheme? And how soon should we expect that realistically?
Well, in principle, all the states are on board, in principle. We are in negotiation with each one of the states for sorting out the nitty-gritty and to make the whole process seamless. But in principle, states are on board. States are being engaged for coming on board in terms of IT fabric, the empanelment and operational criteria, and also, how to take it forward, making sure that the frauds don't happen, making sure that the quality is assured. And also it stimulates growth of the health sector, as well as huge strengthening of the public health system. We want to enable our public health system, the district hospitals and the medical colleges and hospitals and so on, to be a very, very strong partner and implementer of this scheme.
Well, I have a
Mr.
question.
Paul, before I have two very special guests here, Sujatha Rao as well as Shailaja Chandra.
Yes.
Ms. Rao, go ahead with your question.
Well, Dr. Paul, you're saying you're trying to make this binary of outpatient in the primary care sector, and inpatient costs will be borne through a public-private partnership under the insurance scheme. I mean, it sounds nice, but the issue is that you're positioning the wellness clinics as the main core element of primary care. Which is well said, I agree with you. But then, back of the envelope shows that just the wellness clinic alone, I'm not talking about the PHCs or the CHCs, would require an investment of almost 30,000 crores. 30,000 crores. And what is being made available today is 1,200 crores. So, and this is only the beginning, because you need about 300,000 people, trained people, also to be put in the mid-level providers, the mail workers, and so on. So the time lag is going to be so huge by the time the OP part of it catches up. I don't know how these are being looked at as tandem and as a continuum. If you can clarify that, that would be nice. Because largely, I believe you have to increase public investment, and there's no getting away from that. Within this 1%, this is a very ambitious goal.
Paul, if you can explain the math to us, sir, because that's a question that many people are asking.
Okay, coming to the points made by Madam Sujatha Rao, let me respond by saying that the commitment to develop a strong primary healthcare system and a strong public health system above that is a clear commitment of the government. It's enunciated in the National Health Policy, and the initiatives of Ayushman Bharat emanate from that. The point that is it only the health and wellness centers at the sub-center level? The answer is no. It, in addition, also engages the primary health center. The primary health center, in combination with the sub-centers, which means for about 30,000 population, you have a network of 6 sub-centers and 1 primary health center, which will be upgraded to a full-blown health and wellness center complex. Now, about the issue of budget toward that direction, ma'am, you are right that there will be increased need of budget. We are spreading this effort up to 2022. And whatever it would take would be made available, and that's the commitment of the government.
But what will it take, sir? No, but what will it take? Mr. Paul, if you can give us some realistic numbers, sir, what will it take? We understand that you're committed to giving whatever it takes, but what will it take, sir?
Well, I think it would be above 20,000 crore over a period over this period of time, because we are talking about 1.5 lakh health and wellness centers, rural as well as the urban component of this. And typical cost that we estimate at this point in time is, something like 10 lakh an ongoing cost and about 7 lakh upgradation cost. And these estimates could be fine-tuned as we move along. They may be a bit less or a bit more, but that's the ballpark figure that we're working with. So indeed, there'll be so much more need for money over a period of time. We are making a beginning, and this year is the phase of acceleration.
No, sorry, I'm interrupting you again. 20,000 crores till 2022, is that what you're saying?
Yeah, or more, because please remember that the infrastructure cost could vary depending on the existing structure. Our whole emphasis is on enlarging the services, reaching out to people, mass movement, and to make sure that the whole spectrum of primary health care needs are fulfilled. So we are pushing the services, pushing the diagnostics, free medicines, as well as building and upgrading the existing infrastructure as the requirement may be. So as we move along, money would be needed. This year, we are beginning with a certain quantum of budget. If need be, more budget shall be available, because this year is very important for us in terms of making sure that the proof of principle goes to a level of scale that it builds up to even further acceleration in the years to come.
Before I get Shailaja Chandra with her question, a quick clarification, Mr. Paul. When you speak of 20,000 crores by 2022, this is the kind of investment that you expect on the PHCs, right?
Well, the health and wellness center across the sub-center and the PHC as one hub and spoke model, both in the rural as well as in the urban area. So about...
Shailaja Chandra, ma'am, go ahead.
Yeah.
You know, Dr. Paul, I don't know whether you are aware of the spatial distribution of the health facilities. You know, 6 lakh villages are covered today by 1,30,000 sub-centers and by 25,000 primary health centers. The distance from villages to the nearest primary health center ranges between 5 kilometers, 5 to 10 kilometers, and more than 10 kilometers. These are distances which are rather long for people who do not own any kind of a vehicle and are dependent on state transport. I'm once again trying to bring to your notice that there's nothing wrong with the scheme. It is a good idea and it should be done. But unless it is viable, unless it is something which can work on the ground, after all, even in the poshest colonies in Delhi, you will have, even for a distance of 500 meters, a person would prefer to go to an unqualified practitioner than go to a charitable dispensary or a government dispensary. Because even taking those 500, half a kilometer, walking and walking back for a daily wage laborer means about half a day gone after waiting for the doctor. So please, I would only urge that while these ideas are excellent, they must be thought through for 6 lakh villages in the country. We're not talking about just a handful of people here and there. These villages are of large sizes and small sizes. And the census data has not changed. It isn't as though everybody has come to live in urban centers. There are still more than 50% people living in those villages, and 56% of them are just manual laborers. Please keep all these things in mind before these generalizations are given.
Can I just respond very briefly? Ma'am, the points that you made are valid, that the distance should be a consideration. Number two, the population served by a sub-center should also be a consideration. These considerations are a matter of detail, and that they will be kept in mind, that the people don't have to waste a day's labor and wage to reach these points, and a woman can carry a child for a consultation comfortably and go back home. But the second part of this is also important. Please, part of our primary healthcare endeavor includes outreach activities, at least by two models. One are ASHA workers, and one of the ANMs will have outreach activities of a defined, components, mother and child, and maybe old age care, mental health. So home visiting and outreach is one. Secondly, we will beef it up with mobile medical units as required, depending on the terrain, depending on the topography of services that may have to be done. So please view this in comprehensive.
Dr. Paul,
yes.
Okay.
Dr. Paul, I would just like to, you have been an AIMS doctor, you've been in charge of pediatrics. I do feel you should understand that acute illnesses can't wait even for a couple of hours. I hope this will be factored in, because with all the experience at my command, I can say that is the missing link.
Okay.
Ma'am, the emergency care flows not through the ambulatory system of the health and wellness centers. It flows through a quick call to be made to a call center for an ambulance and to reach the first point of care that would be made available. So that system operates already under the NHM. Huge gains have been made in this direction. And that would remain part of our primary health care by definition.
Yes. Ma'am, I'll just come to you.
Ambulatory care and emergency care, we have NHM model which we will strengthen and will increase efficiencies thereof. And by having the NHPS available, it is now possible for a poor family to reach out to the nearest private sector hospital as well for immediate care, and a priority packages that apply to emergencies will be a high point of NHPS.
It's not very often on live television you see this quality of discourse and questioning of government officials by experts. Sujatha Rao, I'll come back to you in just a second. But Mr. Paul, for the benefit of the layperson who is watching this program, sir, what is the rollout date of this particular scheme? And also, sir, on the IT blueprint, we are given to understand that a health stack has been put together. Nandan Nilikani is also advising the NITI Aayog on that. If you can give us some sense of when we can expect to see the details of the IT blueprint and the rollout date, sir.
Well, the IT blueprint is being seen as two levels of activities. One, the immediate backbone, IT backbone for the NHPS, which can help us roll out immediately, which builds on the experiences of the states. And we are very close to a closure on that, and in a matter of weeks, that will be ready for scale-up. At the same time, we are building simultaneously a much more comprehensive health stack that you are referring to, which will absorb a lot of IT and digital health elements into it, in addition to be the backbone for NHPS. It will also connect to individuals and the families and having e-health records and so on. So it will connect the primary care, secondary care, as well as tertiary care. It will connect entitlements. It will connect with records. It will connect with analytics that we will perform. So both the tracks are being followed. But for the purpose of rollout of NHPS, we are making a huge and a very rapid progress, and we are on track with the timeline that we have.
Okay. A quick question from you, Sujatha Rao, before we close.
No, I don't have a question. I just have a comment. You know, the tragedy is that in India, we do say a lot of things, a lot of good, well-sounding, pleasing things in our documents, in our speeches, it's all well said. And I cannot disagree with Dr. Vinod Paul even for a second, and he knows that. But the issue is, why is it that unlike China, unlike Thailand, unlike Turkey, unlike any country you ask me, don't we do any serious, solid, at the table counting, costing exercises? We still don't know how much it's going to cost us. We don't know what the implications of institutional reform are. We have no clue about the kind of manpower required, because whatever design of the system you're drawing up has to do with the disease burden. And the disease burden is very different in the south as it is to the north. So the whole package of costings, diagnostics, medicines, the manpower, the skills, competencies required vary from place to place. You just can't keep on talking about RCH in a state like Tamil Nadu, which has 15% of aged population, and they have 75% of the disease burden is on account of non-communicable diseases.
Okay.
So the whole, you know, I think that's very important. And Dr. Paul, one point I just want to say through you. Dr. Paul, please, I beg of you, use your presence in NITI Aayog to get good, sound, solid health economists to sit down and do the analysis work, and to look at the figures and the numbers and the financing of this whole attempt. Otherwise, everything is beautiful in terms of ideas go.
Dr. Paul, plenty of suggestions coming your way, sir.
Yes,
let me end then by asking you.
Yeah. Yes.
Let me end then by asking you, sir, that you know, we've seen you give us a lot of the details, but I'm sure a lot more needs to be worked out. In terms of the insurance companies that you hope to get on board, in terms of the tendering process, etc., how far are we from that stage, sir? Because again, you know, what we are given to understand is that the package rates have not been decided. They will be decided, I would imagine, on the basis of volume and so on and so forth. So can you leave us with some sense of how that is going to work?
Essentially, you know, respecting the guidance Madam Sujatha Rao is giving, we all agree with those insights completely. We are going to go ahead on the basis of the best information that's available to us, reaching out to the best people in the country, which we are already doing, and above all, building on a huge experience of implementing reasonably good programs in several states where programs of this nature have already seen a sustained rollout. So we are not starting in a vacuum. We are not starting from a clean slate at all. Secondly, the things that you mentioned, as we move along, we will create and strengthen the systems which give us analytics, which give us the ideal way of costing, pushing standard treatment guidelines, pushing accountability framework, grievance redressal. This will all evolve. We are not starting from a scratch. Whatever we are starting is the best that we can put together. There's a hell of a lot that we can begin with. And as we move on, we will improve, we will refine, and make the best program in the world.
All right, Mr. Dr. Paul, we wish you the very best of luck, and we truly appreciate you joining us here moments after the Cabinet has given its approval to the Ayushman Bharat scheme. Also, many thanks to Sujatha Rao and Shailaja Chandra for giving us insights on live television.